Welcome to week 3. This week we're going to talk about some of the high-risk disorders that impact the pregnancy. These disorders can occur in the antepartum time frame, meaning during the pregnancy. They might not manifest until actually they're in labor and delivery, and some of them might manifest in the postpartum time frame. But it's something that can impact the overall health of the pregnancy, so we're going to talk about those disorders. Our sweet little baby. We're going to start with talking about the hypertensive disorders of pregnancy. Hypertensive disorders are the second leading cause of maternal death, and it's related to some of the complications that the actual high blood pressure actually causes, such as stroke, an abruption, which is where part of the placenta, part or all of the placenta detaches from the uterine wall prior to the delivery of the fetus, and that means baby's not getting any oxygen during that time frame. And we're going to talk about some of those other causes that these hypertensive disorders can cause. Keep in mind what we said last week, that according to the CDC, the number one cause of death in our pregnant women is usually abuse. In pregnancy, we have two types of hypertension. One that occurred prior to the pregnancy and it has nothing to do with the pregnancy. And then we have a group of hypertensive disorders of pregnancy that are directly related to the pregnancy. So chronic hypertension is pregnancy or is hypertension that was known prior to the 20th week of pregnancy. If we have good prenatal care and we have good preconceptual health care, if we know she has high blood pressure, then we can treat that, get that under good control prior to getting pregnant. However, if she doesn't get prenatal care, preconceptual health care, and doesn't come into pregnancy health care until after this 20th week. If we see her after 20 weeks and we know she has hypertension, then we're going to start out by calling it gestational hypertension. So the chronic hypertension is prior to 20 weeks, or it lasts longer than the pregnancy lasts. We get concerned when it's greater than 140/90, but the American College of OB/GYN surgeons says that we have to treat chronic hypertension at 160 or 100, over 100 or higher. Our hypertensive disorders of pregnancy are gestational hypertension, preeclampsia and eclampsia, HELP, and chronic hypertension with superimposed preeclampsia. And we're going to explain all those here in a minute. What are some of the risk factors for the hypertensive disorders? If this is her first time pregnant, she has 6 to 8 times greater risk of having a hypertensive disorder. If she's on either extreme of the age, less than 17, greater than 40, she has diabetes, pre-existing collagen vascular disease or pre-existing hypertensive disease, pre-existing renal disease, she's at higher risk. She's at higher risk if she's multiple gestation, meaning twins, triplets, and higher. Hydatiform mole, and we will explain what that is this morning before we're finished. If she's had preeclampsia in a previous pregnancy, she's at greater risk in this pregnancy. But what's also interesting is if her mom or her sisters have had a preeclampsia in a previous pregnancy, she's at greater risk. And one of the things that we have found out probably in the last 7 to 10 years is that we can't say that this is genetic. We don't know what causes preeclampsia. But what we do know is if the father of the baby, if his mom or sisters have had preeclampsia in their pregnancies, then this mom is at risk, which says there might be something genetic with this, but we don't know. All we can do is say, that's an interesting coincidence, but we don't know why that is. And then if this is her first pregnancy with a current partner, she goes back to this prima gravida. Meaning, if she's had the same father for, 1, 2, 3, and 4 pregnancies, she's not had preeclampsia, then if she has future pregnancies with this same father, her odds of getting preeclampsia are very small. However, if she's had 2 other babies and now she has a new father, she goes back to this prima gravida risk. Even though she didn't have preeclampsia with her first couple pregnancies, The fact that she has a new father for this baby means that her risk goes back up. Gestational hypertension is elevated blood pressure during pregnancy or in the first 24 hours postpartum without signs of preeclampsia. And those signs of preeclampsia are edema and proteinuria. We actually define this as elevation of blood pressure to 140/90 on two separate occasions at least 6 hours apart with no previous history of hypertension, and that this blood pressure returns to normal within 12 weeks of postpartum. If she remains hypertensive past that 12 weeks postpartum, we now change her diagnosis from gestational hypertension to chronic hypertension. Now, in reality, if we have a blood pressure that's 140/90, she's probably going to get sent to the hospital, to either the triage unit or to labor and delivery to be evaluated. We're not going to wait for 6 hours before we repeat this blood pressure. She's going to be sent on over so that we can start watching her immediately. Preeclampsia is the hypertension that we've diagnosed after 20 weeks of gestation. Greater than 140/90. We consider it severe if it's 160/110. And again, that definition is at least 6 hours apart on two separate occasions. But again, if she's sitting at 160/90, we're not waiting for 6 hours before we do something and retake her blood pressure. We're going to intervene because of how serious and significant to the pregnancy this hypertension can be. And again, preeclampsia has proteinuria and it has edema. Although edema is no longer the hallmark sign that it used to be, but what separates preeclampsia from gestational hypertension is, in gestational hypertension, they do not have proteinuria and they don't have this edema. It can lead to vasospasms, which leads to hypoperfusion of the organs. And because of those vasospasms, the blood pressure actually goes up, trying to force blood through those areas that are spasmed down. Because it's spasmed down, we're not getting good blood flow to all the organs, and most specifically to the placenta. So it can cause problems in our baby as well as mom's end organs that don't get perfused well. There might be signs of pulmonary edema. She might have oliguria because of the decreased perfusion of her kidneys. Thrombocytopenia. What happens with this vasospasm is as those vessels are spasming, say that real fast, then it can actually rupture some of the red blood cells. And so those are jagged little things now. And as they are forced through areas of narrowed vasculature, because those are rough surfaces, because they've been broken, they actually damage the endothelium. And so the body's response to that is to send the platelets to heal that endothelium. So she probably has plenty of platelets. They're just used up protecting the endothelium that's been damaged. So when we actually count her platelets, it looks like she doesn't have any. The biggest issue with preeclampsia is what it can lead to. It affects the central nervous system because of hypoperfusion of the brain. And so that causes things like the headache, the blurred vision, hyperreflexia, then on to seizures, maybe cerebral vascular accident, all because the CNS is getting more and more involved because of hypoperfusion. They can also have right upper quadrant pain, which indicates that they have liver involvement, and the liver can actually rupture. So we need to pay attention to those kind of signs and symptoms. It leads to poor placental perfusion. So what do you think you would see on the fetal monitor? Think back to what you learned last week. What are signs of poor placental perfusion? It would be decreasing variability and probably late decels if she's having contractions. Because that placenta is not being perfused well, that means the building blocks are not going across. So we're going to have IUGR, and that's intrauterine growth restriction. That's a baby that's not gaining weight appropriately. Fetal hypoxia, which leads to that decreased variability that you see on the fetal monitor. And then eventually, because of the poor perfusion through the placenta, we're going to see oligohydramnios. And if you'll remember from week 1, that's a significantly decreased amount of amniotic fluid around the baby, which means we have an extremely vulnerable cord. So think back to last week when we talked about fetal monitoring and the veal chop. If we have a cord issue, what will you see on the fetal monitor? A variable. What are we going to do about this? We're going to turn mom to the left lateral decube position, meaning getting her all the way on her left side, which increases perfusion through the placenta and suggestively increases perfusion through the kidneys. We're going to set up seizure precautions. We're going to put her in a quiet environment. We're going to get our padded bed rails up. We're going to dim the lights. We're going to teach her how to monitor her blood pressure and use her urine dipsticks and how to read those if she gets discharged. But depending on how severe this is, she may be in the hospital until delivery. And if she gets hospitalized at 22 weeks, that might be another 10, 12, 16 weeks in the hospital to maintain the health of this pregnancy. We're going to teach her how to do fetal kick counts. And that's where she determines at whatever time her baby tends to be most active during the day, might be after breakfast, might be when she's trying to take a nap after lunch. Whenever her baby's most active, we're going to ask her to count fetal movements. She needs to get at least 10 movements in an hour. And once she does that, she's usually good for 24 hours. That indicates good health of this baby. We may put her on the monitor to monitor for contractions or to find out and make sure that the baby's still doing well, that we still have good variability, that we're not having lots of variables. If she's hospitalized, she needs to be on seizure precautions, like I said. And one of the things that's real important about the seizure precautions for this lady, most of the time when we have a very sick patient, we tend to put the sickest patient closest to the nurse's station. This patient needs to be away from the nurse's station because what's the loudest place on a unit? Typically the nurse's station, with call bells going off, with the phones ringing, with everybody talking and laughing at the nurse's station. That's too much stimulation. So we would want her further away from the nurse's station so her environment really is calm, cool, and collected, and not next to where the elevators opening and closing, not where unit doors are opening and closing. We need her in a quiet environment. Then we may give glucocorticosteroids for lung development. And that's things like your betamethasone, dexamethasone, celestone. It's steroids that we give mom, travels through mom's system, goes to the fetus, and we say it's for fetal lung maturity. It didn't go in there and go, hey, lungs, hurry up and grow up. What it actually does, it stimulates fetal lungs to produce surfactant at a higher rate than they already were, which would decrease respiratory issues in our baby if they were born early. We're going to monitor to prevent progression. We're going to watch for signs of pulmonary edema, and we're going to do that because we're going to listen to lung sounds every time we do vital signs and every time we do an assessment. Strict I&O. Now, they may not be on strict I&O if they're on antepartum, but they might be if they're on labor and delivery and if they're on medication, IV medications to treat this the preeclampsia. And if they're on labor and delivery, they probably are going to have a Foley. Their fluid restriction is typically to about 125 mLs an hour. The drug that we're going to use first is probably going to be mag sulfate, MgSO4. That's magnesium sulfate. And it's 4 to 6 grams an hour over 5 to 30 minutes, and then 2 to 4 grams an hour from that point on, depending on how they responded to this mag bolus. So anytime that we're going to increase our magnesium, we have to take into account how many mLs an hour are they getting to get the dose that they're required to have for magnesium. And we're going to subtract that from that 125, and that's what our mainline IV is going to be. So with the mainline IV and their mag sulfate, they're only going to get 125 mLs per hour. We may induce her labor, depending on how severe this is. We may start her labor or we may move straight to a cesarean delivery. If we're going to induce her labor, realize that magnesium sulfate is a smooth muscle relaxer. And so she's going to require greater amounts of Pitocin in order to get uterine contractions that are effectively going to change her cervix. But we have to give the magnesium to prevent the seizure, so we have to give increasing amounts of Pitocin to get her moving in the direction of delivery. Eclampsia is everything that preeclampsia was. Now we have seizures that aren't attributable to another cause. We have signs of impending seizure. Anything that indicates an increased CNS involvement means that we have an impending seizure. Our DTRs, if those are getting more brisk, that means CNS is getting more involved. She's moving closer to a seizure. And these can be life-threatening seizures, life-threatening for mom and for baby. So we need to try to prevent that. And if not, we need to treat aggressively. And if once she has a seizure, we are going to move her immediately to delivery, regardless of gestational age, because of the possibility of maternal and fetal death if she has another seizure. What's our nursing management? If she has a seizure, we're probably going to increase the amount of MAG. We're going to stay with her. Our first duty to a patient who is having a seizure is to stay with them and prevent injury. Hopefully from your room, you can call for help. That's when you yank the call bell out of the wall and it sends that emergency signal so you can get all the help you want. But you won't leave her bedside in the middle of the seizure to go get help. Need to ensure a patent airway. We're going to give supplemental O2, and if we can, while she's in this seizure, while we're at the bedside helping protect her from harm, if we can get O2 on her, we're going to go ahead and get O2 on her. She's not breathing during the seizure. However, once the seizure's over, she should start breathing right away. And if we have a patent airway and we have supplemental oxygen going, then that means once she starts breathing, she's going to start breathing oxygen at higher than what the room, the air O2 is, which is, we know, 21%. If we put her on supplemental O2, we increase her O2, which means she's going to increase the O2 delivery to that baby. We're going to establish or maintain an IV site, and we're going to start magnesium sulfate if that's not already running. We're going to prevent aspiration, and we're going to do that hopefully because we've got her turned to her side. We're going to have suction equipment at the bedside, but we are not going to attempt to suction her during the seizure. What we have found is that we actually do more harm trying to do that during the seizure, and we end up injuring their mouth, and so they have a lot of blood that they could aspirate on, or we end up knocking out teeth that they can aspirate. So we turn her to her side to prevent aspiration. Suction as soon as the seizure is over. If she's not already on the fetal monitor, we want to get her on the fetal monitor so we can determine the health of this baby and evaluate for expedited delivery. Once she's had a seizure, we are not going to waste time and wait and see if she has another one. If she's had a seizure, we will probably move her to delivery. And then we have this thing called chronic hypertension with superimposed preeclampsia. That means she had hypertension coming into the pregnancy, or it was diagnosed prior to the 20 weeks. And now after 20 weeks, we now see proteinuria and edema. We do know that when they have chronic hypertension, it does increase the risk of preeclampsia. Morbidity for mom is much higher than if she just had the hypertension. And there's a significantly increased risk of intracranial bleed and an abruption. We want to review mom's prenatal history so that we know what the norms are for this mom. We're not going to wait until she gets to 140/90, 160/110. If her normal antepartum blood pressures are 110/60, by the time she gets to 140/90, that's a significantly increased blood pressure. So if we're seeing that they're elevating over what her norm is, what her prenatal visits have been, that's going to increase our risk of suspicion. And we're going to report to the provider that we're seeing these increases that we're seeing changes in her level of consciousness, her DTRs, whatever it is that we're seeing that has us concerned, we have HELP. And HELP syndrome is a progression from these hypertensive disorders, either preeclampsia or eclampsia. And please realize that we're not going to start out with a slowly rising blood pressure. Then we're going to have our seizure, and then we're going to have HELP. We can go from 0 to HELP in an instant. So we have to be prepared, and we have to make sure that our assessments are thorough. And our assessment means that we're looking at our IV site, because if all of a sudden we're bleeding from our IV site, we're bleeding from the epidural site when we weren't doing that before. She tells you all of a sudden she's got a bloody nose, she has bleeding gums. Those are all a sign that she's moving into HELP. And she can have that even with just a minimal increase in blood pressure. It is a progression from these hypertensive disorders, but don't think it's going to be stair-step that you see this increasing. Now it's really high. Now she has a seizure. Now she has HELP. We can have a slight increase in that blood pressure that doesn't really alarm anybody, and now all of a sudden she has a bleeding IV site and she's in HELP. It is a life-threatening emergency, and it stands for hemolysis of red blood cells, elevated liver enzymes, and low platelets. So remember, we talked earlier about why we have hemolysis of the red blood cell. It's because of those vasospasms. It ruptures those red blood cells. Because we have increasing liver involvement, swollen liver capsule from backup because of this hypertension, then it's going to affect the liver enzymes. And then those low platelets, because all those platelets are helping heal the endothelium that the hemolyzed red blood cells have damaged. We might also look at uric acid. We may do a 24-hour urine for protein. And remember, a 24-hour urine for protein can start at any time. It does not have to start at 8 o'clock in the morning or whatever. They may get admitted at 4:30, and 4:30 is when we start that 24-hour urine. So the first urine at 4:30 is thrown away. We start at 4:30. Then 4:30 tomorrow, we're going to have her void one last time at 4:30, and then we're going to send all of that down to the lab. If you miss collecting at any point during that 24 hours, you have to start the 24 hours over, because that can significantly alter your results. You can have DIC, which, if you've had that in critical care already, you know is disseminated intravascular coagulopathy. That and HELP both are a bleeding disorder that can cause them to hemorrhage. And if they have them together, it's an extremely poor prognosis. You cannot have HELP if it's not related to a pregnancy. It might happen in the immediate postpartum time frame, but you won't see it on a med-surg floor. You do not have to know the difference between DIC and HELP, other than to know that HELP is directly related to the pregnancy and to the pregnancy-induced hypertension or the preeclampsia, and what it stands for and how you would diagnose it. We talked about having widespread formation of clots in the microcirculation because all those platelets are helping heal that endothelium. It is not a primary disease, but a secondary event. With HELP, we can have liver rupture. So we want to watch for that increased right upper quadrant pain and all the other signs and symptoms that go with severe preeclampsia. What are some of the drugs that we use to treat preeclampsia? Magnesium sulfate is our drug of choice. And the reason we use magnesium sulfate is because it decreases the seizure potential. And oh, by the way, it also decreases blood pressure because it acts as a peripheral vasodilator. But that is not why we use it. We do not use MAG to treat the blood pressure. We use MAG to prevent a seizure. Want to use very carefully if there's already renal impairment because of her preeclampsia, because magnesium is cleared through the kidney, so it can build up and get toxic very easily. And then this will be a drug that is always on a pump. You would never use this without a pump. What do we do with mag sulfate? Strict INO that we said. While she's getting her loading dose, we're going to do 5 to 15 minute vital signs. Then we're going to go to every 30 to 60 minutes once her bolus is in until she's stable. We're going to do reflexes at least hourly. We're going to watch for the signs of MAG toxicity, institute our seizure precautions. We're going to have calcium gluconate at the bedside or immediately available because it's the antidote for MAG toxicity. We do use magnesium sulfate in our postpartum time frame. If we're using it in the postpartum time frame, a lot of the hospitals, depending on how the hospital is set up, those women may stay on labor and delivery for the first 24 hours postpartum because they're still on MAG. If you remember, we're doing vital signs every 30 minutes to 60 minutes. We're doing DTRs, we're listening to lung sounds, all those kind of things. And that might be too high of an acuity for a routine postpartum floor. But regardless of where she is in the postpartum time frame, remember that up to about 30% of those patients progress into seizures in the postpartum time frame. So we have to be very vigilant in the postpartum time frame. MAG sulfate is a smooth muscle relaxer, as we said. So that's going to increase the bleeding in the postpartum time frame because it's going to allow that uterus to relax. So we tend to increase the amount of Pitocin that we give to make sure that uterus stays clamped down. We would never turn off the MAG because she's having increased bleeding in the postpartum time frame because she's still preeclamptic. She still has the risk of a seizure. Going to continue using our MAG. However, we're going to increase the amount of Pitocin we do so that we can prevent that bleeding. Methergin is another drug that we can use in postpartum time frame to help with postpartum hemorrhage, but we would never use it with somebody that has preeclampsia because it's a vasoconstrictor. It's going to increase her blood pressure even more. And again, in the postpartum time frame, we also want to watch for MAG toxicity, and we want to make sure we have calcium gluconate available. Other drugs that we could use is hydralazine. We want to be very careful about using hydralazine if mom has heart disease. Because it is treating hypertension, it can cause severe hypotension. And if she's still pregnant, we want to make sure that we don't cause so much hypotension that our baby isn't getting perfused, that the placenta isn't getting perfused. Another drug is labetalol. It's an antihypertensive that does not affect maternal heart rate or cardiac output. This drug is contraindicated in women with asthma because it can cause bronchospasm, so we want to be very careful about using it with asthma. Nifedipine or Procardia. It dilates coronary arteries and decreases systemic vascular resistance. Again, we might start mom on MAG sulfate. We run that for about 24 hours, maybe in the antepartum time frame, and then we may try to transition her off to Procardia for the remainder of this pregnancy. Again, this can cause hypotension, so we would want to make sure that we don't give it if mom is hypotensive. And we want to ensure that baby is being perfused, that placenta is being perfused. Another drug that we use is Aldomet. We use it to improve blood flow through the uterus and to treat chronic hypertension. If you remember in the early part of this lecture, I said that ACOG recommends that all women get treated when their pressures are 160 over 110 or higher. This is the drug that they're going to use to treat that. I know that some of you are used to thinking about Lasix when the patients have edema and they have high blood pressure, but we don't use Lasix in pregnancy unless we know there's pulmonary edema, because the edema in pregnancy is not related to a fluid overload. It is not fluid causing all that edema, so Lasix isn't going to help. All Lasix might do is cause more urinary output for mom. It's going to decrease perfusion through the placenta, and it's going to decrease the amount of amniotic fluid because of the decrease in perfusion. So we don't use a diuretic unless we know there's pulmonary edema. So keep in mind that the edema in this disorder is not related to volume overload. It's related to the endothelial dysfunction or the endothelial damage. It's hyperpermeability that is associated with low serum albumin. And why do they have low serum albumin? Because they're losing their proteins in their urine. And so that allows this fluid to leak out of these vessels and it causes the edema. So Lasix does not work for these women, and they don't have edema because of fluid overload. So that is not an appropriate nursing diagnosis for somebody with preeclampsia. When all other treatments fail, we need to move immediately to delivery. If we've given MAG, if we've tried our other meds and things are not improving, we're going to move toward delivery. Now, this starts in labor and delivery, and she's 9 centimeters and +2, and she's going to be delivering within the hour. We may continue along that line. If, on the other hand, things are getting significantly worse, she has not started contracting, or she has, but it's very early, she's 1 to 2 centimeters dilated, we're probably going to move her to a cesarean delivery because we can't afford to let this progress into a seizure. And we're going to move toward delivery regardless of gestational age. And we do that in order to save a seizure, to prevent a seizure for mom, and to prevent neonatal and maternal mortality and morbidity. There's our sweet little baby. Keep in mind, that's what all this is about. That's why we do all of our interventions. That's why we talk about all these high-risk conditions so that we have a good outcome. So this looks like a test question. A client at 36 weeks of gestation presents to labor and delivery complaining of a constant headache for the past 2 days. She also states that her face seems more swollen than usual. What should be the first action of the nurse? If you said obtain a urine sample, I'm kind of happy that you would select that because you at least know that we need to find out if she's got protein. But that would not be the first choice in this case because we sure don't want her in the bathroom getting a urine sample and have her have a seizure while she's on the toilet. If you said place a patient on a fetal heart monitor, again, I'm happy that you're thinking along those lines. You want to determine the health of this baby. But again, that wouldn't quite be right because we don't want her to have a seizure while we're putting her on the monitor. We certainly wouldn't notify the physician of the client's concerns until we did an assessment and had something to tell the physician. So that wouldn't be correct. And so the only other one that could possibly be correct would be to take the client's blood pressure. We would want to know what our baseline is immediately. If we take her blood pressure and it's 110/60, then we can get her up, let her get a urine sample, come back, put her on the monitor, finish our assessment, get a fetal heart rate tracing, and then notify the physician. However, you put her on the monitor and she's 200/140. Somebody needs to be going and calling the physician while somebody else is getting her on the monitor. And we'll deal with it, finding out if she's got protein in her urine at a later time. All right, take a brain break and then come back and let's learn about some of the hemorrhagic disorders that can impact pregnancy.